Well, good morning, everybody, and welcome to the session today as we tackle a very important issue of preventing disease. In preparing for this, I went through a large amount of data, in part because of the experts sitting on each side of me that have provided it to me and all the work that they've done over the years. And looking at it, I mean, we spend $3.7 trillion on healthcare here in this country. Nearly 90% of that goes to pay for chronic disease treatments. Of that, you know, we spend $15 billion through the Affordable Care Act, as well as what companies provide in different plans for prevention. And that $15 billion is over 10 years. So it's a real small percentage. So I'm sitting there trying to understand why we do so little for prevention. And I came to the conclusion that we're probably using the wrong language. We're talking to each other the wrong way. In fact, we were just talking in the ready room about something, and it was a question of if you're going to be called pre-diabetic or we're going to give you a weight loss program, which one are you going to sign up for? Pre-diabetic people probably are going to walk the other way, but if it's around a weight loss program, most people will sign up. So in looking at that, I kept going and digging a little deeper, and I sort of came to the conclusion that the questions in the language, as I said, that we were using are incorrect. And maybe we need to put it simple, because prevention should matter to everyone here in the room. And the reason it should matter, because, well, at least to me, I came to the conclusion that when I asked myself, would I rather prevent a disease, or would I rather go into my doctor's office and be told I have a disease? And when you look at it that simply, prevention becomes both a positive tool and an important tool to prevent the onset of disease, and eventually leads to lower costs in healthcare so that we can spend the money elsewhere or reduce healthcare spending over time. We have so many chronic diseases coming up, especially with Alzheimer's, and you look at the cost of that and what that's going to mean to society and how do we pay for it. So if we don't create some headspace by reducing that health and economic burden of chronic disease, we have a long way to go to do that. But if we don't, this healthcare system we have is not going to be sustainable. So I have 4 people here today sitting on each side of me that come and they look at this from a slightly different lens. We have, all 4 considered global leaders and health experts in their field. We have Lynn Goldman, who is, we'll talk a little bit about public health. Tom approaches this from an innovative insurer's perspective. Michael from food and nutrition, and Chris, as a health economist, has just come out with a recent study that appeared in JAMA that sort of takes a look at the health data by state and disease from 1990 to 2016, and he'll talk a little bit more about that today. So we'll start with Lynn. And Lynn, given your role as both a health and environment expert and running the School of Public Health at GW, and your team's involved in an awful lot of prevention areas. What is your approach? Why do you take it? And what difference do you see your school making in this area?
Well, first and foremost, public health right now presents us with a very large target of things to address, because I think on a global basis, we're challenged by a number of really significant, really pressing public health issues. If you look at slide 17, you mentioned 12, I meant actually, slide 12. You mentioned the fact that we have an epidemic of obesity and diabetes. We have actually seen a tripling of the rates of obesity worldwide, which you would see on the slide if the slide had gone up, but which creates a significant challenge, not for just those of us in the United States and Europe and other developed countries, but as you can see, the very high rates of obesity are beginning to be seen in Asia, in Africa, and in fact what we're seeing is a global epidemic, that as we see development and westernization of diets, less activity, that this is a problem that we're going to have to tackle everywhere. Similarly, we have an epidemic of antimicrobial resistance that's global, and this is slide number 16. We have a center at our school that works on the prevention of antibiotic resistance, and 16, I think, is what you want. That's air pollution, which is a big problem globally as well. But antibiotic resistance is also emanating from all parts of the world. We see in the map deaths attributable to antimicrobial resistance being, not just, again, United States, Europe, developed countries, but also developing countries, including, antibiotic resistant strains of important pathogens like typhus that are emerging. And so this is truly an issue that requires a lot of science, a lot of collaboration between the food industry, medicine, and governments across the world. And my last slide to show you for now, number 5. So as we have been approaching some of these problems, we're realizing that we need to do a lot of work on public health, kind of starting in our own backyards. Number 5 is the slide I like right now, which has to do with the fact that we have adverse environments in communities that people are exposed to that are creating conditions that cause ill health, creating conditions that cause stress, then chronic disease, and also adverse childhood experiences that many children are experiencing. And so our Redstone Center for Prevention and Wellness is working on this through projects across the country, including in Washington, D.C., on building community resilience and trying to attack the roots of some of these problems that are within our communities. So, there's so many things that we could be working on, but those are just a few of the approaches we're taking.
That's great. We are actually going to go for 4 hours today because there is so much to cover. Tom, at UnitedHealth, you cover about 135 million lives. You have data that most people would like to have access to, but you and your team have sort of an interesting role. Would you care to share that with the group?
Sure. I want to first thank everybody for joining us instead of Tom Brady. We appreciate that. I would say that we're large. We're the largest insurer in the country. We have a global footprint, so we're the largest commercial Medicare post-65 and Medicaid. But what's unique about our company is that we go well beyond just insurance. We have with Optum, which represents roughly half of our business. It's a data company, it's a technology company, but importantly, it's also a delivery system, right? So we've been acquiring primary care practices. We have a large retail presence with MedExpress, and what makes that unique is from some innovation standpoint, we're able to pretty easily experiment with different kinds of care models because we have the insurance side where we can offer reimbursement and aggregate members, but then we can very quickly stand up studies with our primary care physician practices without really having to spend a lot of time negotiating or working out the details. We can just test things, and we do that routinely. So what my team does, I'm the Chief Innovation Officer at UnitedHealth Group, but we spend time on more what I would call transformational innovations. I would say, and Ed mentioned this in his opening comments, we're fixated mainly on consumer engagement. Whether it's on the wellness end of the spectrum, how do we address obesity by getting people sort of more active and engaged in better diets, or on the chronic side of the spectrum, which, and again, I think you mentioned this, 40% of Americans have a chronic condition. It represents about 87% of cost. So when we talk about consumer engagement, and I can give a lot of examples of things that we're experimenting with, or things that we've scaled. So on the wellness side of the spectrum, just a quick example, and it's an easy one. We've launched a program about 2 years ago that now we offer to all of our insured members called Motion. And it's really just, it's incentives. You get a free fitness device, you get $3 a day. We've paid out tens of millions of dollars in incentives. We get about a 67% engagement rate. And from a consumer standpoint, this is trying to get people moving, basically. And there's different measures in terms of sort of the way we calculate this. But we see that as very successful. Is there a strong return on it? Maybe. I mean, honestly, by the time we go through a process where we're paying for the devices and offering the incentives, but the point is to try to get people active, and then that leads as a sort of a way for us to connect them into other programs once we know they're engaged. So very specifically, we're using that program now as kind of a gateway for diabetics to say, hey, you've been using the motion program, you're doing great in terms of your diet goals and your activity goals. Can we send you a CGM and actually start to understand how you're doing on a day-to-day basis with diabetes? And so for us, it's a way to sort of understand what portions of the population are engaged, and then we can do further outreach. On the other end of the spectrum, we're doing a lot of studies and pilots with people that have chronic conditions, trying to make basically compliance easy. So FDA-approved devices, and I have examples in multiple areas: asthma, type 1 diabetes, type 2 diabetes, pain management, where we're offering people FDA-approved devices and then in real time sort of monitoring their results and then reaching out to them when we see the need for an intervention. And to my opening comments, a lot of the times we're using our own practices to do that. So it's not UnitedHealth calling, it's a primary care physician from ProHealth, or it's a doc or a nurse from MedExpress where these people have had an experience. And that's more in the sort of what I would describe as experimental phase, but I see that as kind of the future of disease management, which, the way we deal with people that have chronic conditions today is pretty ineffective.
So just a quick follow-up to that. So in the payer world, I want to make sure I say this so I don't get it incorrect. If I look at it a little bit differently in your space, in that innovation space, are you sort of evaluated for these programs, which I think are both innovative and positive for improving health? Are they evaluated on an ROI, or what I probably call an EAI, which is equity after the investment, which provides benefits over a longer period of time?
Yeah, I would say both. I mean, we're a company that's, great at scaling. We've got the footprint to do it. We absolutely look at an ROI. It's how we identify sort of problem spots. We always look to our health economics teams to sort of understand what the impact of a particular intervention could be. But oftentimes, and I mentioned this with motion, are we fixated on a strong ROI there? No. In some ways, it's common sense. And as I said, we use it in other ways. It's not just a wellness program that gets people walking. It's a way for us to understand what portion of the population, how people are engaging with us, so we can make offers that are much more specific to them.
Okay, thanks, Tom. Michael, you are at Google. It's sort of that hub of technology. Could you share a little bit with us? I mean, and you run multiple programs within the service area there. Can you sort of describe the focus Google has given to food and nutrition and why Google and you feel it's important?
Yeah, so maybe as a starting point, so I'm one of the leaders at Google who's responsible for the magic that ultimately makes our organization work. So Real Estate and Workplace Services is the organization that's responsible for both the physical places in which we work, as well as all the perks and services that we provide in order to attract and to retain top talent. The teams I'm responsible for are actually very interesting, actually very related to these days. It is our Food at Work program, fitness, massage, transportation, sustainability, and a few others. And we were brought together fairly recently to really think about actually our services more holistically. But maybe start with food, because that's how I started at Google as well. So food has always been an integral component of our organization. So our organization is almost 20 years old. We're celebrating our 20th anniversary in September. Just think about it for a moment. We're only 20 years old. And food has been part of our culture literally since year one. Employee number 56 was our first chef. Our first HR manager was employee number 60. So we are an organization that hired a chef before we hired our first HR manager. And the way we look at food is truly as a means to bring people together. So we're not necessarily looking at food as a functional deliverer of either nutrients, macro and micro, but really as a starting point, it enables people to come together. It's part of our culture. But as part of actually our journey from being a year 1 company to year 20, we've actually evolved. So we're now in the 4th generation of our organization, and our present philosophy is to be actually food care based, because we really believe that food has a tremendous impact on the happiness, health and well-being of our population, both short as well as long term. And in our organization, we provide food for free to our users. Not free to us, but free to our users. And when you provide actually delicious, nutritious food for free at multiple touch points in an organization, you have ultimately the risk that people might enjoy too much of the good stuff. So you really have to think through ultimately from how do you actually provide something that is great, but at the same time, how do you enable people to make choices? So we've become actually significantly, I think, savvier these days to really to think through what should we offer, how do you offer it, and how do you ultimately create actually a variety of offerings that people can pick from, because each of us has actually individual choices. And what you're starting to see now is as well is that our organization, RUSE, Real Estate and Workplace Services, is part of the same organization, G&A, that People Ops is part of. And I think we're at the beginning of this broader aspiration of really thinking about our overall spend on employee benefits or human talent much more holistically. Because I think it's interesting is that I ultimately control what we spend on food and how we deliver that. And my colleagues in People Ops are thinking through healthcare. So you can ultimately say cynically, I actually make them fat first, and then they show up on the other side. But how do you ultimately prevent that? And then what's interesting as well to think as a corporate employer about how do you spend ultimately your money on benefits, perks, not just on Googlers, those who work for our organization, but for ultimately the family members as well. And I think it's interesting that if we believe, which I think we probably do, that so many of the diseases we're dealing with these days are diet related, it's pretty interesting to think about the future where I think as a corporate employer, you might actually think through not just healthcare benefits, but potentially food care benefits as well, because investing in what your employee base is eating both at work as well as at home might longer term lead to significantly better outcomes. So I think we're at the beginning of an amazing journey to really to think through what impact food can have both at work as well as food at home on the health and well-being of your talent base.
Thank you. Yesterday we had a food retreat that was went about 4.5 hours. I had to leave and it was still going on. So there's a lot of interest in sort of the topic of food and healthier eating and nutrition and food as medicine, a number of topics there. But one of the barriers that came out yesterday, which I think is important to maybe talk about for a second, Michael, is the notion of food waste. When we have people, 60 million people on SNAP as a matter of public policy, you know, and we're wasting 40%, I think, of the food. You know, most of those are the healthier foods that we talk about and vegetables. And you all collect a lot of data. I was wondering if what your data is showing and if we're closer to figuring out a way to solve that problem.
So I think there are so many actually dimensions to your question. So I think as a starting point, so food waste obviously is a core issue for us. We're addressing that with technology. We are investing in LeanPath, which is actually an online platform that enables you to track what you throw out in the kitchens or as well post-consumer waste. And with that, you have actually data of what you're throwing out, the volume, weight, and based on the data, you can make better decisions. But I think that is actually a separate question or issue than how do you get more people to eat more fruits and vegetables. And what we've learned over the years is that it's not as easy as it sounds. So we've been on a journey, so maybe as a starting point, and it's specifically, I think, for our organization, but I think one of the many learnings. So we started with this notion, if you feed a very highly educated workforce more information, they will make better decisions. So if you actually share with your workforce that eating actually vegetables is better than eating actually red meat, they will go for the great vegetables. That didn't necessarily materialize. So step 2 for us was, can you ultimately think through the supply? If you offer more enticing vegetable dishes, will they ultimately consume it? And I think to an extent the answer is yes. But what you get at the same time is that culinary professionals in the world today are not necessarily equipped to make vegetarian or vegetable-based dishes just as attractive as protein-based dishes. It's significantly easier to grill a steak well than to ultimately to grill a cauliflower steak just as well. So in order for us to move our user base to a more balanced plant-forward diet, we've learned that we need to really invest in the skill set as well as the excitement and the engagement of our culinary professionals to get involved in plant-based diets, which is not easy. And I think the third one, which we would call on the policy, is to really to think through what is it that as an organization you really aspire. And I think at times there are the interesting conflicting priorities. So on the one hand, we use our program to attract and to retain top talent. The talent that works with and for us can work literally anywhere around the world. And they don't want to be constrained by choices made by us, the employer. So the moment we will become the food police and tell them, you know, we know it's better for you to eat more of this and you shouldn't eat this and therefore we're going to take it away, that might drive them to go to one of our competitors. But at the same time, I think we have a role to play because one, we care for our talent base short as well as long term. And I think we have a role to play by leading by example. So thinking through what is ultimately your perspective on will you offer red meat in the way you do today going forward, or will you affect change? And I think for larger organizations to take a perspective on that and sticking to that, I think will drive change in our environment as well.
Thank you. Chris, I talked about Tom having access to all this data, and you've probably studied all that data. You recently came out with the journal piece that is, if you go through it, has it was very well done and so rich in data as you broke down by disease and state. I was wondering if you could share a little bit about the trends, where you see things going, and then before you finish answering, sort of the connection between human capital and prevention. You spent last week down with World Bank and IMF and are working with Dr. Kim on the human capital issue. So it's a complicated question, I guess multiple pieces, so I'll let you take them in any order that you want.
Okay, thanks, Ed. So first, just I'm the sort of data guy up here, and I represent or lead an organization called the Institute for Health Metrics and Evaluation. We're in Seattle. We're 400 people. We run a collaboration of about 3,500 scientists around the world, focused on the health, on data and metrics and what's happening in the world. And what Ed was just talking about is we just released in JAMA, the Journal of the American Medical Association, our assessment of health by state in the last generation in the US. So it's an example of trying to synthesize the data that's out there, not fixate on one study, let's say on caffeine and heart attacks, but what does the totality of all the evidence tell us? So slide one is on the first part of Ed's question, which is we quantify both the diseases nationally and by state, and then how many deaths are attributable to each of the major risk factors. And diets at the top here. Diets actually has 14 components behind it. So I think it's an interesting question about it. For example, red meat is a very small fraction of the diet-related deaths in this country. It gets a lot of press time, but it's really not where the action is. And so I encourage you to have a look at the details, because there's a lot of surprises, I think, when you sort of roll up all the evidence that's out there in a systematic way. And then right after you get tobacco, almost another 500,000 deaths, and then you get a series of metabolic risks that are related to diet and exercise indirectly. High blood pressure, high body mass index, so overweight and obesity, high blood sugar, high cholesterol, and then we start to roll into alcohol and drug use as the big determinants in the US. That varies a lot across states. So, here we are in California. California's done a great job bringing down tobacco, so tobacco is much smaller of an issue comparatively, but there's a general theme, if you also look at the trends, that of all the big risks, the one that's getting worst, it's actually the only one where the rates are getting worse, is obesity. Tobacco, the trend's in the right direction, but it's still huge. But obesity is very scary, both in this country and abroad, because it's one of the big risks that's systematically getting worse everywhere in the world. There are places in the world where obesity is worse than the US, but not many. So, that's one context. Now, the other thing that we take is to give that sort of forward-looking view and we'll start releasing this in the summer. We take all the information on disease and risk and say, what would the future look like if the current trends continue? So if you can go to slide 2, this is the rank of life expectancy across countries in the world. And the US is in blue. So on current trends, the US will keep going down the rankings because of the trends, particularly around obesity, but also just generally some of the other adverse trends that we have. And China's in red. It's the one that crosses the US. So not only do we have the great crossover of GDP, we have the great crossover coming, but where as a nation, China will live longer than the United States. Now, the next slide, slide 3, is our attempt in this forecasting framework to say the future is not cast in stone, right? So these are the 10 leading causes of premature mortality: heart disease on the far left, and then stroke, and then suicide, and then road injuries, and then you get into pneumonias and drug use. And the blue bar is the trend we expect on current if things keep going as they are. The red bar is how things can go worse if we actually slip to the rates of change that we've observed in actual populations. So let's say obesity actually speeds up more in terms of the growth, and the green is the best we can hope for given what we've observed across countries. So the main point here is that the spread between red and green is huge. In other words, what we do about risks and what we do about the healthcare system, particularly managing some of those metabolic risks in primary care, like blood pressure, like cholesterol, like blood sugar, makes a huge difference to the trajectory. And so the US is not inevitably going to slip down the rankings. It's not going to fall behind China in terms of health outcomes, but that's most likely. But we can change that trajectory, and that has a lot to do with the topic of this panel around prevention. So just a way to sort of take all the data that's out there, crunch it, and we were sort of happy in The Economist this week. The Economist said what we do on measuring health around the world is imperfect, but it's the best source for understanding health in the world. So we got an endorsement from the Economist. But so hopefully you'll believe us. But to the link to economic growth and what Ed asked about human capital, the banker, Jim Kim at the World Bank, asked us to take all this measurement that we do, number crunching of the basic primary data, and expand that into education, which we've done anyway, and then see what the relationship is to economic growth. And it turns out that countries that have invested more in health and education, being successful at improving health and education, have actually had quite a bit faster economic growth in the last 25 years. And so if that translate that into money terms, if everybody in the world achieved the 85th percentile of progress on health and education, global economic output would have been 0.5 percentage point higher per year, which translates into $13 trillion in the global economy over about a 20-year period. So there are pretty strong reasons to care just about, because people do, and we all do, care about health. But there's increasing evidence that these also have knock-on economic consequences at the macro level. We've always known about this at the micro level, particular firms or particular labor markets. But even at the aggregate level, I think that's the sort of interesting thing here, which is this all ties together in a way that says the trajectory for the future matters quite a bit, what we do about prevention, both in terms of health and in terms of the economy.
Thank you. Lynn, at GW, you've done an awful lot of work on obesity. You have Stop Obesity over there in the Prevention Center. And we've had a lot of conversations on sugar and the impact of sugar on both obesity, diabetes, and others. So if you could share a little bit of information from what you're doing at GW again and what you found, and then how that then relates to what you might be doing a slightly different, it's two-part, the Healthy DC initiative that you all have.
Right. So actually for a number of years we've been working really closely with people in the community in the District of Columbia, and I think part of what we feel we need to do as a School of Public Health is take all the wonderful data that people like Chris produce and say, okay, but how do we translate that into real action in communities in order to promote health? And one thing we do find in a place like the District of Columbia, and I think it's true in many places, including LA, I used to work in public health in California, we see huge disparities between different census tracts or in DC, different even metro stops in terms of life expectancy. And I'm talking about a difference within a single community of something like 15 years of life expectancy, depending on where you happen to be lucky enough to have been born and grow up. And so getting involved with those communities, one can address factors that are very, very relevant to this issue, for example, of obesity. Sugar is an issue, and one thing that we have been doing, one of my faculty serves on this committee for the city called the Diabesity Committee, which is kind of a cute way of saying that they recognize that diabetes and obesity are inextricably linked. And they're starting with, believe it or not, trying to get the sugary beverages out of the hospitals. That if people go into hospitals, just like some of you may remember, we used to go into hospitals and see doctors and other people smoking, and getting doctors to quit smoking. Hospitals were one of the first places that they banned smoking. That made a difference in terms of communicating to the public that this is not a healthy behavior. And so we're very involved with that. We've gotten our own hospital at GW to pledge to be a part of that. I'm very proud of them for that. The other thing that we've done, though, is work with the city about getting our children more active. And that means requiring PE, but it also means using the research that some of our faculty do that say, you know, all PE isn't actually PE, that there's a lot of sports activities that involve things like people stand around waiting for their turn at bat. They're not actually moving around. They're not actually active. And so doing the research on what forms of PE actually promote activity, actually are healthier, and then being creative with the community in parts of the city that don't actually have playgrounds around the schools. And so they're able to create play areas on the roofs of schools, all kinds of locations, so that you get engaged with, you know, the churches might get involved, others in the neighborhood, to make sure those children have a safe place where they actually can play and get outside and be active, which I think probably has other health benefits as well, you know, in terms of some of the things that I talked about before about stresses. So there are many things that can be done, but I think it's important to realize that we don't have all the answers, that we know that there are unhealthy behaviors in this. We're trying, for example, to change the behavior about not just going into the big box supermarket, I won't give a brand for the store, and buying, you know, very cheap cases and cases of sugary beverages for your kids, but frankly also cases and cases of bottled water that people buy instead of buying fresh fruits and vegetables. That if they have limited resources for their kids and they want to do something that's good for them, for their health, probably the first thing to go after is those fresh fruits and vegetables. Actually, the tap water in our community is safe, and parents don't understand. They're trying to do the right thing for their kids, so there's a lot to do. But
all right, it's when you take a look at Washington. So I frequently make a mistake and say we're going to change this by zip code. But really the social determinants aren't necessarily broken down by zip code, because within zip codes you can have it. And when you're looking at doing this by individuals and communities, it's important not to confuse the two, I would say. So I appreciate that. Tom, when we look at both a program that you're doing on diabetes and pre-diabetes, the one thing we know that whether you're pre-diabetic or diabetic, if you can lose 5% of your body weight, whatever that weight might be, you can add up to 10 more years on your life. Right. And for most of us that want to live longer, right, that's not a bad thing to think about. So could you share a little bit more of what you've got going on there? And,
yeah, it's interesting. So the diabetes prevention program has been around for 20 plus years and never effectively scaled, right? It's an evidence-based weight loss program. It said this 5% body weight, independent of your going in weight, you reduce your risk of converting to full-blown diabetes by 50%. So if this were a drug, it would be a blockbuster, but it's not. And we've spent about 10 years trying to figure out how to scale it and made all kinds of errors along the way. And honestly, the first thing we did is we called it the Diabetes Prevention Program, which from a consumer engagement standpoint is not attractive. And then the second thing we did is we really focused on trying to create a bricks and mortar. And all this is a group intervention. You get people together, and it's about a 9-month program. And we tried a national program with the Y to offer these the DPP at no cost. We were screening people to identify them as pre-diabetic. And oftentimes you'd screen someone and tell them they were pre-diabetic, and they would say, "That's tremendous news. I'm not diabetic." So they'd walk away feeling good about themselves. They weren't symptomatic. So all kinds of sort of traditional consumer engagement problems. Ultimately, though, we always think about how do we scale this, how do we offer this up, not just to UnitedHealthcare members, but through Optum to across other populations. And so we did an experiment with NBC and Comcast where we developed a reality TV program of pre-diabetic people that went through this together with celebrity coaches. And it was just a test to see if, in fact, we could engage people virtually. And it was incredibly effective for a lot of reasons. And these are really basic things. One, it was entertaining. Two, it was on demand. So people would literally watch the episodes and participate via their Comcast box. So we took those learnings, and that was a full study that we won an Emmy for, which was kind of fun. But we took that full study and created a program called Real Appeal, which is, and we literally hired the guys that developed Beachbody to do it. So it is a highly entertaining program that's not called the Diabetes Prevention Program. It is the Diabetes Prevention Program. People respond to it. We're not screening them. It's basically a free weight loss program, which people want, and they can do it on their own time. So we have hundreds of thousands of people now enrolled in this, pre-diabetic, diabetic, and not even on the spectrum, people that just want to lose 5 or 10 pounds. So it's a great lesson in sort of how to actually try to scale programs like this, and we reimburse it. It's free. So if you're a UnitedHealthcare member, Medicare, Medicaid, commercial, it's just free weight loss, and the participation rates are really, really high. And we're replicating the DPP outcomes, back to that 5% weight loss, and we're seeing also just really high participation because again, it's on demand. It's you watch these episodes and participate with a coach on your own time.
How long has the program been in place, and do you have enough data there to show that the weight loss has started to show some benefit, or do like many people go through that weight loss program and then sort of appear like the Dow Jones, they drop and they go back
which
up?
You do see in a lot of diets, right? But this isn't a diet. This is really it's a lifestyle intervention, is what the DPP experts would say. We've had the at-scale model in place for roughly 2 years, and we're not seeing attrition in terms of people going back and regaining the weight. So
Okay.
the clinical outcomes on this have been really strong.
Great. We talked a little bit about obesity, and the Institute actually released a report back in 2016 on weighing down America, and it's been updated, and Hugh Waters is here, and he's responsible for that report. And back then it showed that $1.4 trillion of negative impact obesity has on the economy. And it's updated to where now the data almost looks like it's 1.6, 1.7 in that range. And the way Chris was explaining the trends, it looks like that number will continue to go up. But Chris, in looking at a number of pieces of data and just really calling more on your experience and what you see out there, what are some of the changes that you see, both behaviorally or in a matter of public policy, might help reverse those trends?
Well, I think if you look at the other big risks like tobacco, there's lots of success stories. I think there's a crystallized policy package for reducing tobacco consumption. Same for air pollution. Same for a number of the other big drivers. The really disturbing thing about obesity is that there is no country on Earth that has reversed obesity to date. It only goes up. Now, some countries, the rate of growth is slower, And it's so grim on the data front at the community level that the World Health Organization's aspiration for obesity is not to lower it, it's just to stop growth in obesity. Whereas every other global aspiration is to, make real progress and reduce things. And I think that reflects that it's actually pretty challenging. There are, small-scale studies in school kids or in, a particular place that hold out some promise. But these have not, despite all the policy attention and concern about obesity, these have not replicated well. And so I think we're in that phase where there's lots of good ideas ranging from, increasing physical activity and getting sugar-sweetened beverages out of schools and taxing sugar-sweetened beverages, and, a variety of other sort of interventions around total caloric intake, composition of calories that are being proposed, but we don't actually have the large-scale success stories yet. And I think should be super concerning, and we should be really focused on trying to find more of those.
And
unfortunately.
at what point do we pull the alarm and say we can't wait any longer?
Well, I don't think we can wait any longer. You have to act on what limited evidence there is now, just because the trajectory is so alarming, both for cost and for health. And so I think you really need to act on all the sort of hints that are out there around obesity. It's only probably in the last maybe 4 or 5 years that there's really been the high-level policy awareness that it's a real threat looming on the horizon. So perhaps it's just that natural lag of people trying to take action.
Okay. Lynn, and you and I have talked in the past about the impact climate might have on obesity. Would you want to share some of that with the group here?
Oh, certainly. And I mean, at first, I'm just going to agree with what Chris just said, that the time is now to take action. But we need to do it in a way that involves evaluation of the things that we're doing, implementation science, as you may. Can't just say, well, scattershot, do everything that we have as the tool in our toolbox, and then just hope some of it hits a target, and then we don't know what things we should be scaling up. So, but yeah, it's well past the time to act. So I would agree with that. But there is this connection with climate that's very interesting, in the sense that some of the very same practices that we do that lead to overeating, lead to obesity, are also damaging the planet. The kind of agriculture that we're doing, the way that we are raising food animals using grains, they produce methane themselves. We're not thereby, sequestering carbon in our soils. We're creating a lot of issues that contribute to climate change. And then, of course, things in our lifestyle that involve use of automotive transportation, the way we use energy, the way we generate energy. Both, we're not as active as we should be. If we walked more, if we cycled more, that would probably be beneficial to our health. So those very activities that make our lives more convenient, whether it's air conditioning indoors or lack of exercise, also contribute to climate change. So we've been talking about this as kind of a syndemic, that these activities are harmful to our planet, and but also are harmful to our health personally. In terms of obesity, it's not that obesity causes climate change or that climate change causes obesity, but there are many of the same root factors that are behind each of those. And I think that there's some real opportunities, therefore, also to, for example, something that we're doing a lot in DC, again, make cities more walkable. Try to incentivize people to get out of their cars and move on, using their own feet, using cycles. And DC, those of you who've been there recently, it's a little inconvenient if you're used to driving around and suddenly there are all these bike lanes everywhere. And there are all of these, these city bikes that you can take and come and go with, and lots of sidewalks in places where there didn't used to be, and so people are a little confused, about how to get around the circles. But you do see a lot of people moving around more, and it does make a difference in health. Again, not a benefit that's being shared in every neighborhood and every community, something that we need to spread, to all the neighborhoods. But I think something that has a lot of side benefits in terms of our environment as well as our health.
Thanks, Lynn. Michael, the idea of food as medicine has been talked about a lot and growing, and I know, Tom, you can jump in on this as well, but if you look at food and think of food as medicine and try and think 3 to 5 years downstream, and you look at the changes that Amazon has made with Whole Foods, what are your thoughts about grocery stores, whatever that might look like, whatever that becomes in the future as a distribution change? Do you see that sort of becoming a pharmacy of the future that is sort of a combination of food and medicines? Traditional medicines.
Yeah. I'm so conflicted about it for a variety of reasons. So I think on the one hand, the retail will change dramatically over the years to come. And I really believe that the retail experience will be much more about helping individuals to create whatever experience they're looking for. So if you go to a retail store as of today, you can pick about a gazillion different options within a specific product category, but you're not being helped to create ultimately a great dish or a great meal. And I think that is going to change because with the on-demand economy, you pick the dish, they'll figure out what ingredients you need, and you can get them. So I think that's all going to change. What I'm challenged by is that we can talk about the functionality of food and the elements that you need to eat more or less of in order to be healthier going forward. But I think at the same time, food is such a big part of our culture and who you are. And I think that you have these conflicting priorities where on the one hand, I know I should eat more of this, but at the same time I want to eat with my family or with my friends, or the emotional benefit I get out of eating something that might not be great from a functional perspective, but the emotional actually lift I get from eating that is not necessarily taken into consideration when you just think about the functionality of it. So I think that it is going to be a function of all of the above, is where for some, food will become significantly more medicine. But I think at the same time, we should not necessarily believe that people are going to be functional eaters going forward. It is part of our culture.
Yeah, I mean, it's interesting. And did you have something you wanted to add on that? Or?
Yeah, I would just say if you think about sort of the way healthcare is becoming more retail, right? So putting food aside for just a moment, if you look, I think the Healthcare Cost Institute came out with their annual cost report about 3 months ago, and it showed a decline in primary care physician use of about, I think it was 16 or 17%, but a fairly significant decline in PCP use. It didn't mean that people weren't seeing primary care, they weren't getting primary care, they were just getting it in different sites. Rather, it's in the, the urgent centers, in the pharmacy that has urgent centers, virtual visits. And so I think as you see healthcare, very specifically start to move towards retail, well, then there's opportunity there to connect to other forms of retail, including, nutrition advice, discounting on healthy foods. I mean, so I see those models ultimately, they will connect. But I think it starts with that sort of use of retail healthcare services that can then extend into things like, food and, other forms of sort of health status activities.
If I may add, I mean, one of the challenges with that, and we're seeing it in the antibiotics area, where in those urgent drop-in clinics that there's a lot of prescribing because they don't really know the patients, they're not sure if they're going to be compliant, will they come back, they don't know them. They don't have records from the other places that they visit because they may go to this one this time and that one that time. And the need to tie together the medical information for individuals, if we're going to have, that kind of shopping pattern, for medical care. I'm a pediatrician. I can tell you, without having any records, it's very difficult to be confident about what I'm actually seeing. I don't see the growth chart for the child. I don't know, what did they look like 2 years ago compared to what they look like today? And so you lose that continuity, and I think that we have to kind of face the fact that this information revolution that we're in has to extend to that people have the ability to bring all that information with them when they go into those places.
Yeah, we do need sort of portable individual health records that are integrated. I would completely agree with that.
a question for another day on portability of insurance plans and stuff. That you know, part of today when you're looking at sort of, and United does an incredible job of offering different, of having different offerings for their individual members and companies. But there is a portability issue where people move from plan to plan. Any thoughts on how we solve that moving forward?
I mean, we're making that investment now. Where by 2019, all of our members will have individual health records that are portable.
Okay.
So,
if you you're also working on something for asthma, which sort of reduces the emergency room visits, that has both a patient benefit and a cost benefit. Could you share a little bit about where you are with asthma?
yeah, and this falls into sort of the broad kind of digital health category, right? That's getting a lot of buzz. But and I mentioned this up front. We're doing a lot of sort of experimentation with FDA-approved devices that we're offering up to members that have chronic conditions, and then we have nurse teams that look at the data on a day-to-day basis. So if you think about how you control a chronic condition, you know, whether it's asthma for your kid or diabetes, you don't have data, you're sort of seat of the pants, you see a specialist 3 or 4 times a year, and the system it doesn't work very well from a disease management standpoint. So asthma specifically, we've done several studies, and now we're moving a scale on this where we've taken kids' inhalers and put Bluetooth devices on them, coupled with an activity monitor, and we're able to actually understand on a moment-to-moment basis how frequently they're using it and pulmonary function. So you can see if Johnny's out on the playground and he's using his inhaler really frequently, we can do outreach to the school nurse and rein that in. And only about 55% of kids have adverse effects during the course of the year, and that can be really terrible adverse effects, not just ended up in the ER. So the whole idea behind this is to say, use these devices that are inexpensive and then kind of redeploy our nurses who today do telephonic outreach, which typically people don't pick up, you don't have data, you're just checking in. And I will say this, and I go back to consumer engagement, we're doing these kinds of digital health studies with a lot of different populations, but with kids, the enrollment rate in these studies is immediate. Like we fill these studies so quickly because parents want help. When you're saying to a diabetic, hey, can we put a CGM on you and help you manage your diabetes, a lot less success, right? And it depends on that, and that's where we're doing a lot of experimentation, is we have more success if a primary care doc asks that question versus the insurer. So we understand that. You know, you have to sort of test different outreach models, but the basic premise is get these devices out there, see how we get people to enroll and use them, and then do passive monitoring and outreach when somebody's in trouble.
That's impressive. I think, and as the father of 7, I was sort of blessed that none of mine had it, but I know that you worry enough with your kids as it is. So.
And it's honestly, like we did one with type 1 with Children's Hospital, and it's the same thing with the kids. It's the parents are looking for ways, and that's a very difficult disease to manage on a day-to-day basis. The enrollment rates are outstanding, the participation rates are outstanding, and the clinical outcomes are really encouraging so far.
All right, thanks, Tom. Chris, some of your data on mortality, I found interesting, especially when you're getting into, I mean, there's some on substance abuse. You want to go through that a little bit with us? I think at this time when we're dealing with opioid addiction and the growing epidemic that's there, I think some of this data may provide a little bit more light.
Yeah, I think it was really surprising to me and to the team working on the U.S. that essentially you can divide the U.S. into 2 groups of states. In one group of states, which is 29 states, death rates in children and adolescents, death rates in younger and middle-aged adults, and death rates over 65, 70 have been going down pretty steadily. There are another group of states, 21 states, where death rates in kids are going down, death rates in the over 55s are going down, but the death rates between ages 20 and 55 are going up. And this is not in the last 3-4 years. This is actually started in 1997 or 1998, and it's just a straight line up. Now, we've gotten a lot of attention for good reason about the opioid crisis, and that's sort of really kicking up even more. But whatever is driving this, splitting of the U.S. into two groups started 20 years ago, and didn't really get picked up very much at all until it sort of got to pretty much epidemic proportions in places like West Virginia. So what's driving that? And in the JAMA piece, we try to split out all the causes that are contributing to that. And it certainly, opioids is part of it, but not the whole story. Suicide's going up in those states where mortality rates are rising. Liver cirrhosis, mostly related to hep C and alcohol, is going up in those states. Diabetes is also the states, no surprise, with the obesity belt that runs from Oklahoma right through to West Virginia, where obesity's gone up even more than in other parts of the U.S. So it's really pretty unusual, and because often people report on these sort of rolled up measures like how long people live, like life expectancy, and because in the states where death rates are going up between 20 and 55, that signal's masked because things are getting better for kids and getting better for the over 55. So you're missing the signal that things have been getting worse for 20 years. And I think it's all about using much more, using the disaggregated data that we have available. We've got pretty good data systems in the US compared to many other countries. Certainly very good for death and causes of death. And there's just a lot in there to tell us that something's been going awry. And it's not like, I think, the populist version of this, which it's in the last 3-4 years. It's really been almost a generation.
I've noticed the same thing, Chris. And one thing, and I'm wondering what you think about this, but it has seemed to me that possibly a leading indicator for that is those are the very states that first saw the epidemic of child obesity. And that started kind of, Mississippi, the Appalachia, that same belt. And then those children who were first becoming obese are now those 20, 30-year-olds. So I just find that intriguing because I think there might be a kind of a cohort phenomenon that people are starting out less healthy in life, and then as they're entering midlife, they're at much more risk for mortality from all kinds of causes. I mean, much of which seems to be involved, obviously, with things like drugs, smoking, suicide. So somehow in that that mental health access, but unhealthy lives really over their entire time, at least that cohort. I think more study would need to be seen. Those people committing suicide, were they obese youngsters or not? That I'm not saying we know that because we haven't looked.
So, really interesting study coming out of the UK very soon, which the world's biggest analysis around things related to obesity. 50 million person years of studied. And, a huge number of cancers, heart disease that are related to obesity, really surprising findings on some outcomes like suicide. It may be that it's one of the few things where obesity is actually protective.
Might protect.
Against suicide. It's in their result. It's very surprising. I think there's lots of arguments you could argue that maybe it's because artificially, because people are losing weight, because they're depressed. So you've got to worry about reverse causation. But I think you can understand the patterns in the U.S. at least with two things, and then the question of how related they are is wrong. One is the sort of so-called deaths of despair, the suicide, alcohol, drugs related. And the other is these cohort effects of obesity, and they may be related. That's less clear, because if you look at the states that are going up, the balance of those two can be a little bit different, but there is that belt where they're both coinciding from Oklahoma right through to West Virginia.
Right.
Well, we're almost at the end, and so I'm 5 pages worth of questions short of finishing. So, but one question I think that I'll toss out there, and you can answer it either from a reimbursement or a policy position. We're looking at ways we need to communicate differently with individuals and communities out there to accelerate any pace of change. But at the same time, there are reimbursement models that probably need to be changed, policies that need to be modified or amended. So I'm going to ask each of you to, as I know some of you are deeply involved in some of these, and I'm going to just let you tell me what you want to want to address on those issues, because we'll be taking notes and then following up with everybody. We'll be launching a chronic disease prevention series probably early this summer at different institutions or universities. So we'll follow up with anybody that's interested in that. But I'll turn to you first, Chris.
Closing comments?
You can go to closing comments or the question that I ask. I'll leave it up to you.
You know, I think that the way to intervene and on the prevention front and on making progress on some of the risks is both the sort of public policy stuff, but there's also a lot related to individual interaction with the health system. And the one that I just keep coming back to is if you look at county level outcomes in the US, like life expectancy, 3/4 of the variation across counties, which is just huge, you know, 20 plus years from best to worst, is related to 5 big dominant risk factors. And 3 of those risks are really fundamentally, one of the best mechanisms is through the interaction through healthcare. And you've got to incentivize, those are blood pressure, cholesterol, and blood sugar. And we need to think about ways, some of the experiments the UK has done and others, to give them more prominence in the process of care. And I think that does relate to reimbursement, that does relate to the incentives that we provide. And it relates to rewarding providers with reducing risk of their or helping patients reduce their risk, and providers being their partners in that.
Lynn?
Just one thing I'd say, you know, start with health and healthcare with children, and especially in the schools, in terms of having, you know, availability of better food, you know, physical activity required, but also even further back, pregnant women and their children. We still have women who are smoking during pregnancy. The diets that many women have during pregnancy, children who are born low birth weight and or preterm are from the very beginning at a disadvantage for all these things, for obesity, for diabetes, chronic health disease risk over a whole lifetime. So I think we have to start early.
Tom?
Yeah, I'll take it, I think, mainly from a reimbursement standpoint. You know, we're talking about things like food, you know, delivering food, virtual visits, my sort of digital health, where you might be saying to an endocrinologist, you're not going to see your patient in the same way that you have before, but when there's a need for an outreach, we want you to do it. And it might be telephonic, it might just be changing the meds. So from my perspective, none of that works, right, in a fee-for-service environment, right? And so that's what it describes is this need to really move, and I think we are, but it takes a long time, but towards, you know, what the industry calls accountable care organizations. Really, it's just kind of the full risk deals that says, you know, if you're going to take risk for a diabetic, then you're going to be willing to offer up nutrition advice. You're going to be willing to do telephonic outreach if they're hooked to a sort of a digital health solution. You're going to be willing to divert them to another type of care, whether it's retail. So to me, it all comes back to we've got to move in order to bring all of this in and actually pay for it. We've got to move more quickly towards these accountable care organizations.
Thanks, and I agree with you, because it's so many wonderful things going on out there, but the ability to make anything affordable and accessible becomes. We didn't get to get into that topic today, so I apologize. But
I'm going to give it back to you. It's outside of my area of expertise. So I'm going to give it back to you. It's outside of the area of my expertise.
Okay. Well, everybody, thank you very much. That was a lot of material, not enough time to cover it all, and I appreciate your being here and wish you a great time at the conference. Thank you very much.